Hello everyone. This is a little bit of an unusual video for me to make because usually I make educational videos for patients and their caregivers, but this time I've decided to do something really different. That is, I've decided to kind of look at the FDA's approval of the blood-based biomarker that happened just last week and share this information with everyone, including my fellow neurologists and other practitioners who might order or have to interpret these tests. So I'll go ahead and get started. So this was just last week when we had a new blood test that was approved by the FDA for Alzheimer's disease. So really exciting time and really excited to look at the scientific process that the FDA follows and what is the underlying data in these studies. So let's go ahead and get started. So the FDA had this news release last week, and they said that this new test provides a less invasive option, reduces the reliance on PET imaging scans, and it also increases your diagnostic accessibility. So let's look at this test. Before we do that, let's kind of think through the current practice. So currently what we do is we have patients who would complain of cognitive impairment. And once we have such a patient, we do some kind of objective cognitive testing. This could be as simple as doing a MOCA or an MMSE, or if needed, also sending them to a neuropsychological evaluation. And if on the basis of these testing, we feel that this individual might have Alzheimer's disease, we then order confirmatory tests for the underlying pathology if the patient and their family is interested in knowing about this. And it's usually a PET amyloid scan or a spinal tap, a CSF study to look at the amyloid and tau proteins in the spinal fluid. But more recently, we have had this development of biomarkers. And in 2024, last year, we had Alzheimer's Association work group that gave their recommendations or consensus guideline for the new definition of Alzheimer's disease. In this paper, they do talk about what is the minimum requirement for a reliable Alzheimer's disease biomarker. And they say that at least the biomarkers should have an accuracy of 90% at predicting moderate to frequent neuritic plaques at autopsy, which basically translates to if I'm saying this person has Alzheimer's disease based on this biomarker, and if we look at their brain under the microscope, they should have at least moderate to frequent neuritic plaque or the beta amyloid in their brains. This is one of the requirements, or we could use an approved surrogate biomarker to diagnose Alzheimer's disease in the right clinical settings. And the approved biomarkers or approved surrogate biomarkers that we have in the field include the PET amyloid and the CSF that we had just mentioned right now. Now, for the blood-based biomarkers, this paper said that to have an accuracy for any blood-based biomarker that is being developed to be at least equivalent to the approved CSF assays. Now, when we talk about accuracy, just to refresh our memory, we are thinking about the number of individuals who are correctly diagnosed, whether true positive or true negative, divided by the number of individuals who were tested. So that is what we are talking about when we talk about accuracy. Now, blood-based biomarkers have been an interesting and fascinating aspect for Alzheimer's disease, and they are really ideal because they have these properties of being really accessible, as well as the fact that you can do a large number of blood tests really quickly. And on the screen, you'll notice this star that has appeared in the blood-based biomarkers. We also call it as p-tau 217. This biomarker, out of all the blood biomarkers, has been one of the star performer. That's why I've put it in a star. But the problem is, as we have rapid development of these blood-based biomarkers, we have a lot of different kinds of assays that are available. So a lot of different ways to check for this protein in our blood. And there is not a lot of standardization for this. And, I personally am going to start my own center And as I was putting together the white paper for the Dementia Center at the University of Texas in Tyler, I came across so many ways to test for the single protein. And one of them is the single molecule array, and then I have the names of the lab in front of it. Then the other method to test for this protein is mass spectrometry. And then chemiluminescence enzyme immunoassay, quite a mouthful, and we have a few labs that do that as well. Now, the one test that was approved by the FDA is the chemiluminescence enzyme immunoassay. And interestingly, it is not the p-tau 217 alone, it is the ratio of p-tau 217 and the amyloid beta 42, which was approved. And we'll look further into this test because it sounds like a very interesting name. In addition to the process of the blood test that was approved being very interesting, the name of the test is again very mouthful. So it is Lumipulse G p-tau 217 divided by amyloid beta 42 plasma ratio. And Lumipulse G is the name of the equipment that does this test, and p-tau 217 divided by amyloid beta 42 is the ratio of the two biomarkers that we do in the blood, and that's how the name got so big. Now, I also found out that the particular approval this test got was the 510(k) clearance by FDA. And we'll look into all of these one by one. Starting with the chemiluminescence assay. If you are familiar with ELISA, it's very similar to that, but if you're not, then we'll kind of go over every step one by one. So the first step that is a part of this test is having these paramagnetic particles that are coated with antibodies. And this is the first kind of substance in the test. And once we have that, we introduce our sample, which in this case is the serum or the blood of a patient. And we know that the serum has these antigens which are going to go and eventually bind with the antibodies that are with this paramagnetic particle. Now, why, for some reason, we have this paramagnetic particle? The reason for this is that after we have this binding or immunological reaction between the antibody and the antigen, we can separate these bound particles with the help of just magnets. And we call it first bound and free separation when we place magnets around the vial that has this fluid and we have our antigen that is bounded to the antibody. Once this is done, we can then introduce another antibody in testing. And this particular antibody is now tagged with an enzyme. The particular enzyme that is used in this test is called as alkaline phosphatase. And the red part here is the enzyme, and the green part here is the antibody. And once this goes into the solution where we are testing, it also binds to the antigen. So now we have this second immunoreaction that has taken place. And then we use, again, the magnets to kind of separate these bound antigen-antibody complexes from the rest of the fluid. Once that is done, we drain the fluid and introduce the next set of fluid, and this is what we call as the substrate for this enzyme reaction. So this enzyme and substrate is kind of a lock and key arrangement. The name of the substrate is very long, but the short form is AMPPD. What it does is it goes and locks into the enzyme, and then there's a chemical reaction. And once that happens, we have a release of this photons or light. And this is what we call as chemiluminescence. And this is what is detected by a photon detector, which in this case is built in the single system where you put in your sample. And it also has a photon detector, which is also called as Lumipulse G. And so we kind of have looked over or looked and talked about the chemiluminescence enzyme assay. And we've talked about the Lumipulse G, p-tau 217 divided by amyloid beta 42 ratio. Now, what is this 510K clearance? So when I looked further in FDA's news release, I read the sentence that said the FDA found that Lumipulse G p-tau to 17 to amyloid 42 plasma ratio is substantially equivalent to the Lumipulse beta amyloid 42 to 40 ratio, which is the previously authorized test that uses CSF samples. And so I said, okay, there is a step before this approval of the blood-based biomarker that I also have to understand. But before that, I was also curious about how do FDA has this clearance of devices or tests. And what I learned is that the classification is based on the perceived risk from that test. And so the first kind of approval that you can get from the FDA is the pre-market approval. This is for high risk appliances or tests. Then we talk about de novo classification. This is for low to moderate risk, and this is something that you have to apply if you have no legally marketed predicate device for something that you want to get approved for. And coming to 510 pre-market notification. So this is the one where the risk is similar to de novo, low to moderate risk, and there is a legally marketed predicate device in the market. So this was the approval FDA gave to the blood test, but it does kind of talk about an approval that was given to for the CSF test, and that was the approval, the de novo approval, based on which the blood test got a 510K approval from FDA. So I wanted to look into the data myself, and I did find that this approval was done in 2022, and this was for the CSF amyloid 42 to 40 ratio. Now, I also was very curious to read this paper and see for myself what do I think about this approval. But this was not a study that was published. So this is something else that I learned during my journey, that for FDA approvals, you have to submit a very rigorous report, and FDA does release this report. And for the CSF, this is a decision summary that you can easily search on the internet and you can easily go through it by yourself as well. But because I went through it, I can summarize it for you as well. So the de novo submission and approval for the CSF was based on ADNI dataset. Now, this is a dataset that ADNI standing for Alzheimer's Disease Neuroimaging Initiative. It's a well-known dataset in the Alzheimer's world. And within this dataset, what Lumipulse did was it studied individuals from 55 to 90 years old who were part of this data set, and the conditions that they looked at were subjective cognitive impairment, early mild cognitive impairment, late mild cognitive impairment, and dementia. And this is how they kind of segregated these individuals. So subjective cognitive decline is a designation that's given to individuals who are just having some cognitive issues, but when we test them, we don't find any objective findings or objective evidence for the decline. And we do this in multiple ways, but in the ADNI data set, they used a scale called Clinical Dementia Rating Scale. That is what the CDR here is standing for. And this is the global score. So if on this scale, if you scored a 0, then we said that you have subjective cognitive decline. But if you scored 0.5, those individuals had mild cognitive impairment. And if you scored a 1 or more than 1, then those individuals met criteria for dementia. Now, the way they discriminated between early and late is based on a specific neuropsychological test, which is also called as logical memory test. And on this logical memory test, if your performance was about a standard deviation below the normal, then you have the early mild cognitive impairment. But if your performance is more or equal to 1.5 standard deviation, then you are in the late mild cognitive impairment stage. Now, in this study, the goal was to compare the CSF test from the Lumipulse and to find out how good does it match with the amyloid PET scan that also looks for amyloid in the brain. And in this test or in this submission, we talked about the visual PET read, which we kind of look at the PET amyloid scans with our eyes, and whatever read we give to that scan, positive or negative, was considered the gold standard. And in this test, what I also learned about FDA's approval was that the CSF cutoffs were determined before doing the study on the patients. And how can someone do that? Well, they looked at a different set of patients in the ADNI data set, and they performed receiver operator characteristics analysis on them. And based on that, they said that, oh, if your ratio for A beta 42 to 40 is this number, then this is what we think the PET amyloid should be, positive or negative. So this is really essential because this was not a post hoc analysis, not after looking at the data. You say, oh, I think these patients who have positive amyloid, I'm going to say that these are the ones, this is the level of CSF ratio number they should have to get the positive PET amyloid scan. So we'll kind of also visualize it, and sometimes that makes it easier. So this is the test result category that Lumipulse came with, and it said that if anyone had beta amyloid 42 to 40 ratio less than 0.05 or equal to this number, we call them positive. And the prediction is that the PET amyloid should be positive. If they have this ratio equal to or more than 0.073, then we call them as CSF negative. But if you're in between these numbers, then we say you're in the indeterminate zone and likely you're positive. Now, one thing that I want to kind of talk about quickly before I talk about what was found and how much concordance was there with the PET is the fact that amyloid beta 42 goes lower in our brains as we deposit it in the brain. And so when we test the CSF, individuals who actually have amyloids deposited in their brains, they will have amyloid beta 42 number that goes lower in the test, which is a little bit counterintuitive because when you're testing for something abnormal, you want that number to be higher. But just with CSF, amyloid beta 42, later we'll see it for plasma, these numbers go in the opposite direction. So the less it is, the more worried we become about beta amyloid being deposited in the brain and not clearing out in the CSF and the blood. So that is the reason you see that we are calling the individuals whose beta amyloid 42 ratio to the 40 beta amyloid is less than 0.058. Now, this was then compared to the PET status, just as I was kind of talking about earlier. And rightfully so, most of the people who were put in the category of positive had positive status on the PET. And those individuals, based on their CSF A beta 42 to 40 ratio being put in the likely positive status, also had PET positivity, and then we had this negative prediction and negative PET, but this was not one-to-one. So there are some individuals who are positive on the CSF, and we are comparing how many of these were also positive on the PET. And so this is how we look at these numbers. So for the first cutoff, for the positive cutoff, we had 171 individuals who were rightfully predicted or true positives in this case, where the CSF test said they are positive, and the PET amyloid, the gold standard in this study, agreed with it. So 171 divided by 177 gives us the predictive value of 96.6%, which is wonderful. Now, when we look at the negative, that concordance between the first number 78, that is for the CSF test that says it's negative, and when we look at the PET amyloid scan, it is also negative, 78 over 93. That gives us a negative predictive value of 83.9%. So those are wonderful numbers for a test. Now, in addition to these numbers, the FDA also looks at a long list of analysis. The test has to be reproducible, reliable across the lots of the testing samples across the site. There's something called the hook effect that when you have a lot of positive antigen or the testing, something that needs to be tested positive, there are some times when just because you have so much of positivity in the sample that it sometimes gets tested as negative. So for this submission, Lumipulse also did increasing concentration, or in this case, decreasing concentration of beta amyloid, or tested different concentrations and saw how robust this prediction was. And we will not go into that data just for the sake of this talk. But one thing that I do want to highlight, and this is for my fellow peer neurologists, because this question has come up so many times, that is, I have someone who has CSF amyloid 42 to 40 ratio, and they are in the threshold to be called positive. You just told me that amyloid PET, they have good concordance with amyloid PET, and the positive predictive value is 96.6%. So can I call them to be having Alzheimer's disease? Now, and similarly, we have individuals who are in the negative zone of the CSF test, and they have good concordance with PET amyloid. Can we call them not having Alzheimer's disease? And we also have this intermediate zone. So one thing that we know for sure about this kind of cutoff values is when you have someone in the intermediate zone, you definitely have to think about the test of time or doing another test. So you could repeat a lumbar puncture after a few months to a year, or you could do another test to confirm. So if I have some kind of indeterminate results in the CSF, I could also check for a PET amyloid in the clinical settings. But what was really, really interesting, if you read the FDA's approval notice, they say below this positive ratio that a positive result does not establish a diagnosis of Alzheimer's disease or other cognitive disorder. So I got really confused. Wasn't this all the point of what we're trying to do to diagnose Alzheimer's disease? So then, and this is the document that I was talking about that I have earlier referred in the talk. So then I looked at FDA's definition of calling a test, how they call a test, and what it means. And FDA calls something as a diagnostic test when it can confirm the disease just by itself, something that just aids or helps and is a supportive evidence for a diagnosis is called as aiding diagnosis. And something that you can screen a lot of people just to find the disease early, including the asymptomatic individuals, those who have no problems. So in our case, no memory problems, no thinking problems. We call it a screening test. And then there is a rule-in test which helps to confirm the presence of a disease. Rule-out test means that if you do it and if it's not present, then it helps to rule out the disease. Among which of these does this CSF beta 42 to 40 ratio meet the criteria for? And what I found was it does help in aiding the diagnosis. It does help to rule in and rule out. We just talked about the positive predictive value and the negative predictive value. It's not a screening test. So a lot of people, since the time this test has been available, and especially, this is especially relevant for the blood test because not a lot of people will undergo a lumbar puncture just to find out if they're at increased risk for Alzheimer's disease. But when you have a blood test, people are really interested, it's really accessible, and then they want to test even if they're not symptomatic, and they want to know if they have underlying Alzheimer's pathology. But this test, at least in the CSF, is not approved for just screening. And, we will look at the blood test as well in a while across the same parameters. Now, in this talk so far, we have reviewed the CSF data. So we'll start talking about blood right now. And what was released in the news was that this test is approved for individuals who are 55 years or older and those who have cognitive impairment. And this was also a multi-centric trial run at different places with almost 500 individuals who were tested. And again, as we were talking about positive predictive value and negative predictive value, what the FDA has so far released talks about a 91.7% positive predictive value for the blood test when you compare it with either CSF or the PET scan. And the negative predictive value was also really good, 97.3 for the blood test when you compare it with CSF or the PET. So the concordance between these different ways of checking for the same proteins was very good. They also had about 20% individuals with this indeterminate result, where what would be recommended would be to do further testing to confirm. Now, I was very curious. I just wanted to look at this approval notice just as I did for the CSF and go through it and review it for you. But this is not yet released, so I'm desperately waiting for it. But what I found in the interim was a supportive study. Now, this study was published very recently again in 2025, and it also looked at the plasma biomarkers p-tau 217, p-tau 181, and other beta amyloid biomarkers in the blood. And this study was a part of the INTERCEPTOR project in Italy. And before we kind of talk about the study, very little information just about the project so you kind of know where this data is coming from. So the project Interceptor, as I said, is a study that is done in Italy. It was a multi-centric study at 20 centers. And the purpose of this project is to have a standardization of the biomarkers collection. Just as we were talking about earlier in the talk, we have so many different ways to look at even a single blood-based biomarker, and also to have centralized final evaluation so that the results are more robust. And the kinds of biomarkers or the things that they looked at included MRI, PET metabolism or the FDG study, EEG, CSF, serum biomarkers. This is our plasma biomarkers, as well as the ApoE gene. And they followed individuals for 3 years, including doing neuropsych testing every 6 months. Amongst the 499 individuals, about 356 developed MCI during the screening through the 3 years. And out of these 356 individuals, 306 individuals also had the plasma biomarker testing. And this is the number that we study the concordance between the plasma and the CSF biomarkers. So that there are two objectives of this study that I had mentioned earlier. And the first one was to just see how good are the plasma biomarkers as compared to the CSF biomarkers, and to look at the diagnostic performance of each different plasma biomarker. And as we talked about, the study participants were those 306 individuals who had mild cognitive impairment and who were a part of this 20-center multicentric study. Among these individuals, 160 were females, 146 were males. Mean age was 72 years, plus minus 7 years for the standard deviation. And what they did was based on the CSF. So in this study, the CSF became the gold standard. And based on the CSF thresholds that they defined, they divided individuals two times. The first time they divided based on just the amyloid positivity or amyloid negativity. And the next time when they did this analysis, they divided them into amyloid and tau positivity and negativity. So there were four possible combinations of this positivity and negativity for amyloid and tau that we'll look into now. Now, this just as we were talking about, so the definition for the CSF-based criteria or base classification was if your amyloid beta 42 to 40 ratio was less than 0.069, then you were considered to be amyloid positive. If your CSF p-tau 181 was more than 56.5 picograms per ml, then you were considered tau positive. So this is the number of participants that tested positive for amyloid in the first row, and then negative for amyloid, and then amyloid positive and tau negative in the third row, both amyloid and tau positive in the fourth row, both negative in the fifth row, and the sixth row was amyloid negative and tau positive. So we will look into the figures for this paper. But before we do, I wanted to kind of ask these questions and pursue them together with you and think through these questions. So, the first question that I want to pose is which plasma biomarkers correlate best with the CSF biomarkers? And so we'll look at a series of graphs now, and I will orient you first to what we are looking at. So on the x-axis, you see amyloid beta 42 in the CSF, and on the y-axis is where we are very interested in looking at, that is the amyloid beta 42 in the blood. And all these units are in picogram per milliliter. And we will now see correlation plots. So what do we see for beta amyloid 42, just that biomarker alone when we look at CSF and blood? Well, we see a weak positive correlation, and we do see a lot of colors here. What I want you to focus on to make it easy is to look at the blue and the green shapes. They do kind of cluster in the left side of the graph, which agrees with what we talked about amyloid beta 42 earlier. These individuals are all amyloid positive per the test, and they are depicting a lower value for both amyloid beta 42 in the CSF as well as the same protein in the plasma. What we see for amyloid beta 40 is that there is no correlation. And when we look at the ratio amyloid beta 42 to 40, both in the CSF on the x-axis and the y-axis has the blood, we see a very strong positive correlation. You also see this clustering of the blue and the green, the lower end of this quadrant, which also agrees with what we talked about this ratio earlier and how beta amyloid goes down in individuals who have Alzheimer's disease. Now, what about p-tau and 181 plasma? Well, when we look at the CSF and the numbers for the blood on the y-axis, what we see is that there is a positive correlation. It is not as strong, but there is a positive correlation, which basically means that increased amount of p-tau 181 in the CSF correlates with having also an increased p-tau 181 in your blood. Now, for this kind of comparison, we don't have p-tau 217, which has been the star so far. The reason is we don't have it in the CSF, it's only in the plasma. So we don't have this kind of correlation curve to look at. So we did see which biomarkers correlate well with the CSF, and amyloid beta 42 by 40 has the most positive correlation amongst all the curves we saw. Now, we want to see, can these biomarkers discriminate between this Alzheimer's pathology and not Alzheimer's pathology? So we will look into further curves and graphs, box plots to be specific. And what we will see is on the y-axis, we have the name of the biomarker. In this case, it's amyloid beta 42 in the blood. And on the x-axis, we have their amyloid status, amyloid negative versus amyloid positive. And the status is based on the CSF biomarkers because in this study, we have CSF as the gold standard. And this is something that I just said out aloud. And when we look at the box plots, we find that beta amyloid 42 in the blood, if you have amyloid positive status, does go down as compared to when you have the amyloid negative status. And it is statistically significant. When we look at the same thing for beta amyloid 40 in the plasma, we find no statistical significant difference between amyloid positive or negative. So this is not a good biomarker. And when we do the ratios, we do see this kind of better separation between the amyloid negative and positive. It is also statistically significant. And when we look at the blood-based biomarkers of tau, p-tau 181 and p-tau 217, these numbers, are expected to go up, just like other abnormal tests where your numbers usually go up. And you do see on the right half of both the graphs that the box plots are higher for amyloid positive. This was expected, and they both show a significant difference for amyloid negative and amyloid positive. So, to kind of look at all these figures together, what we find is amyloid beta 42 does a good job of separating between amyloid positive and negative status. So, we're still talking about the blood test. And what we see is that this distinction becomes much more tighter when we have amyloid beta 42 to 40 ratio, even though 40 by itself is not helpful, but when we put it as a ratio, it does make these box plots kind of move away from each other, and this distinction becomes more cleaner. And on the p-tau, we see good statistical significant differentiation between amyloid negative and amyloid positive. Now, how can we just go about our ways by making things simpler for other people? So now we have this very wild kind of comparison, and we have so four groups to compare, which is so difficult. And so what I've done in this part of the talk is to kind of visualize the fact that here the left part of the graph is amyloid positive and the right part is amyloid negative. And I've also simplified kind of thinking about these pathologies. If you have amyloid positive and you have tau negative, or if you have amyloid positive and tau positive, we are thinking about Alzheimer's pathology. And both of them are on the left side of the graph. But if you have amyloid negative and tau negative, or amyloid is negative, but tau is positive, we are talking about not Alzheimer's pathology. And in addition to that, the whole discussion of the field has been how early can I determine that I have this disease? Because earlier you determine, the more effective your interventions will be. And so within these graphs that you will see in the next few slides, I also want you to focus a lot more with the distinction between the first two on the left, the ones who only test for amyloid positive versus the ones who test for both amyloid and tau positive, because that would be a biomarker that would, if something can differentiate even between them, then that's a biomarker that's looking at the earliest abnormal biomarker that we can see just with the blood. So again, in these few graphs, the y-axis will have the blood and the x-axis has the status of the individual based on their CSF biomarkers. So the first graph we are going to look at is for amyloid beta 42. And we actually see that it differentiates very well between all these states. And as expected for the amyloid positive states, that are on the left end of the graph, the box plots are lower, which is what we expect. We expect this number to go lower when you have amyloid in the brain. And when we see it for amyloid beta 40, it is not a surprise. Unfortunately, this biomarker does not do well in CSF, does not do well in the blood as well. But the question is then why do we even want to measure it? Well, the reason is if you do it as a ratio, if you take it as a ratio of the 42 to 40, it's a really good combination of biomarkers to look at. And that is the reason we keep talking about amyloid beta 42, even though you've seen how it does not perform very well by itself. Now, again, here, I want you to notice how tighter the box plots have become. And on the end, on the left side of the graph or the plot, you see the amyloid positive status for both the first and the second column. And you do see that these numbers are lower as compared to the amyloid negative status. All these differences are statistically significant. Now, while doing the study, I found out, or reading about this, I found out that the paper that I was reading all this about had a little error, and it is discordant in terms of what they're trying to say. And what I have written here, that you do see that this ratio is increased in amyloid negative tau positive individuals as compared to the amyloid positive status. Unfortunately, for some reason, the paper says it's the other way around, that it is decreased in amyloid negative tau positive status, which probably is most likely an error. So I'm going to write to the editor there. Now, looking at the p-tau 181, we said that we expect this biomarker to increase when we have amyloid or Alzheimer's pathology in the brain. And that's what we see here. And these, I have talked about how it can differentiate very well between the both amyloid and tau positive status as compared to the negative amyloid and negative tau status, or negative amyloid and positive tau status. And looking at the same graph, but now for p-tau 217 instead of p-tau 218, you again see that these numbers are increased for the amyloid positive. And now we kind of look at all of them together and we see very similar trend that we were seeing just with doing amyloid positive versus amyloid negative. Here we see that when we have a ratio of amyloid beta 42 to 40, the performance is much better as compared to just having beta amyloid 42 or beta amyloid 40. And now, we kind of have gone through that the fact that plasma biomarkers can discriminate between the pathology for Alzheimer's. And the next question is, which you have been so desperately waiting for, is which is the best one? Which one should I use? And before we go into that, I will go into the fact that there is a trend towards going for ratios instead of individual biomarkers. But why is that? So we have this p-tau 217 by amyloid beta 42 ratio, the plasma ratio of these two biomarkers that is approved. But why? Why are we suddenly looking at the ratios? Now, the reason for this is biomarkers, by just themselves being alone, they are absolute values of something that you measure in blood or any other fluid. And these specifically, if you're talking about the ratio that is approved, and if we just look at them separately, these vary by the rate of protein production in our brains. This also varies based on how our blood-brain barrier is secure, or if it's leaky, then we can have more leakage into the blood. And it also depends on how my body, how is my kidney, how is my liver, how quickly are we metabolizing, so that even when we do a test, we are not detecting it. And it depends on the labs that you do the test, or how there is any variation in the way the test is done. In addition, we all have some kind of other diseases, or we are taking some medications. All of this is interacting with the testing that you're doing. What happens when you take a ratio of two biomarkers? Well, basically, you're normalizing for these kinds of differences. So it kind of normalizes the test. So if you remember throughout our presentation till now, we have talked about how A beta 42 by 40 ratio is a way better predictor than A beta 40 or A beta 42 by itself. And that's the reason because we are balancing out these differences that apply to both of them. We will now look at the plasma ratios because we have talked about how ratios are better. So let's look at some ratios apart from beta 42 to 40. So we are now doing p tau 217 and 181 divided by the amyloid beta 42. And this is really interesting because amyloid beta 42 and 40 come from the breakdown of the same protein, but these are two separate proteins. The other reason it is interesting is these two proteins move in the opposite direction. Amyloid beta 42 goes down, p tau 217 or 181 goes up. So this should be also very helpful. So when we look at 181, we do see that individuals who have amyloid positive status based on their CSF will have higher ratio of p-tau 181 divided by amyloid beta 42. And individuals who have amyloid positive status again will have this higher ratio of p-tau 217 divided by amyloid beta 42. And these differences are statistically significant. Now, again, to kind of complicate the picture and make it more complex, we introduce the tau status as well. And to orient you again, the amyloid positive is on the left side of both the graphs. And what we see for amyloid, for p-tau 181 divided by amyloid beta 42 ratio, as well as for p-tau 217 divided by amyloid beta 42 ratio, is the fact that they can differentiate between these different states of disease, and p-tau's performance, as you can see, is more robust across all the four comparison groups, and all the differences that it is doing are statistically significant. So you can, with the help of p-tau 217 divided by amyloid beta 42 ratio, you can discriminate between amyloid positive tau negative and amyloid positive tau positive. That is the early stage of the disease. And if you look on the curve on the left side, you do see that even p-tau 181 and amyloid beta 42 does this discrimination very well, and these are all statistically significant. Now, yes, but which is better? And what is the overall verdict? We will look at what is called the receiver operative curves to answer that question, and also to answer what is the verdict for overall diagnostic performance. Now, going back to again reviewing Y ratios, we did talk about how they normalize the inter-individual variability. We also talked about how they capture disease-specific dynamics. So specifically for Alzheimer's disease, we have one protein, amyloid beta 42, that goes down. Other protein, p-tau 217, that goes up. So this opposite movement of biomarkers can be captured very well with a ratio. And they increase diagnostic accuracy. This is something that I haven't talked about, right? And I'm going to talk about it. So when we talk about diagnostic accuracy, we usually look at receiver operator curves. And these curves have the y-axis that has the sensitivity and the x-axis that has the specificity. And the idea here is to have as much of area under this curve to increase your diagnostic accuracy. And there are so many curves on the screen. Basically, we are kind of comparing the different plasma biomarkers, and based on their ability to predict amyloid positive or amyloid negative status on the CSF. And instead of getting confused and looking at all those numbers and colors, what I did was I looked at the highest number, I picked up a winner, and I said, okay, this is the one that I care about here. So the winner here was p-tau 217 ratio with the amyloid beta 42. The area under the curve here is 0.87, which is considered good. And this is the gray line, the topmost line or the topmost curve that you see. And you can visualize that this has the maximum area under its curve. And this is the test that got approved by FDA, this specific combination of biomarkers. But if we continue to look further and if we try to combine biomarkers a notch further, what we can do is we can combine, instead of taking a ratio, we can combine a ratio and another biomarker, or we can combine these two biomarkers. And when they did that, the winner came out to be this green line. And what is it? It is the amyloid beta 42 to 40 ratio in the blood with the p-tau to 17 in the blood. And this time, the area under the curve was 0.90, which is considered to be excellent. We also do another test here where we are looking now at the amyloid positive and tau positive status versus negative for both. So Alzheimer's pathology versus not having that pathology in the brain. Which is the biomarker that does the best here? So you see this gray curve on, which is the topmost curve here. And when you look at it, it's the p tau 217 divided by amyloid beta 42. To remind you again, this is the test that FDA has approved. And the area under the curve is 0.91, which is also considered excellent. And again, if we look at the combinations of a ratio and a number, p tau 217 with the ratio of amyloid beta 42 and 40 comes out to be a winner when you're trying to look at the whole Alzheimer's pathology of amyloid and tau positive and amyloid and tau negative. This is the green curve. And this time you can increase your area under the curve. So this is a test that FDA has approved, rightfully so far that we have looked into it. But the question is, what does it mean? Can I order it for someone who's worried about their cognition? I am in general neurology practice. I don't have a lot of time, but I have a lot of patients who come and they're worried about their cognition. Can I just order it to see if they have Alzheimer's disease? So we come back to the definitions that FDA gives to the tests. And we look at that and then we think through it. Now, this is my best prediction based on all the data that I've looked at. I'm still waiting for the final approval notice. But before that, because it's out there, everybody's excited. I did want to kind of think through this and kind of have my best predictions of what and where can we use this test and where we cannot use this test. So aiding the diagnosis, yes. If you have someone who's symptomatic, if you do a test assessment, you fully analyze the individual with the history, with the objective cognitive test, and you are worried that this pattern of cognitive impairment that they have is fitting Alzheimer's disease, then do this test and it will help you. It will be a supportive evidence for you to say, yes, this individual may have Alzheimer's disease. It is a good test to rule in. Again, you need to have someone with symptoms. You need to have this objective evidence of cognitive impairment. And in that case, you can use this test to rule in. It's also having a high negative predictive value. So you can help or you can use this test to rule out Alzheimer's disease, again, in the clinical context and setting. It is not a test that you can just do on someone who's not symptomatic and you do it and then it's positive or negative. It's not something that you just diagnose based on just the test itself. You have to have the right clinical context. Now, this is where it is very controversial. We have a lot of individuals who will want to have this test, rightfully, understandably so. But the problem is that we do not have enough data to say this by itself can support a diagnosis of Alzheimer's disease. The definition of Alzheimer's has been changing. In 2024, we had two conflicting definitions of Alzheimer's disease. And the other ethical question that arises is if you are doing it just based on the test, or if you're doing it for screening in asymptomatic individuals, you don't have access to other tests for confirming it because they are not approved. The CSF and the PET amyloid is not approved in asymptomatic individuals. So what do you do if someone is not having any symptoms, they get tested, they are positive. So ethically, you cannot do anything with them because it is still not proven. This, by the way, may change as we are having some studies that are being done. There are studies being done with donanemab, with the plasma biomarker, and kind of even seeing the course of the disease with the donanemab infusions. We have other studies that are also being done looking at this plasma test by itself, for looking at the patients, for seeing if this by itself is enough to get you in an anti-amyloid study. But until we have more data today, at this point, there is no justification to use it just as a screening test or as a diagnostic test in the absence of the clinical degree of suspicion that you need for Alzheimer's disease. So, this is a talk that is dedicated to all individuals who suffer from Alzheimer's disease. I know I went on and on talking about the biomarkers, the pathology, the FDA approval, but at the end of the day, this is a disease that affects people. And that is why this talk is dedicated to those individuals. All this scientific movement that we are having is for individuals who have this disease, it is for their loved ones. So hopefully this was helpful. I will keep you posted as we have more exciting developments in the field.